Hi, everybody. My name is Tess Killian, and I am so happy to welcome you to the 5th Annual Cannabis in Practice webinar series hosted by the Washtenaw County Health Department and Livingston County Health Department in partnership with the Washtenaw County Medical Society and Livingston Physician Organization. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This webinar is being recorded. The webinar recording and presentation slides will be available on our website at washtenaw.org/marijuana in the coming weeks. Before we get started, we ask that all questions for our speaker be asked through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar for the speaker to answer questions. And now I am pleased to introduce today's speaker, Dr. Karen Osilla. Dr. Osilla is an associate professor in psychiatry and behavioral sciences at Stanford and a licensed clinical psychologist. She conducts health services research with a focus on delivering substance use services to underserved populations using innovative solutions that decrease health access disparities. Dr. Osilla has received funding from the National Institute on Drug Abuse and National Institute on Alcohol Abuse and Alcoholism, the Patient-Centered Outcomes Research Institute, and has published over 100 publications on this work. She has been conducting addictions research since 2006 and has been involved in over a dozen clinical trials evaluating cognitive behavioral therapy, collaborative care, and motivational interviewing interventions, web and in person, for mental health and substance use disorders among youth, adult, military, family members, and other hard-to-reach populations. So now, thank you so much for joining us today, Dr. Osilla, and I will let you take it away with your presentation.
Wonderful. Thank you so much for that introduction, Tess, and it's wonderful to be here with you all. I know that sometimes on Zoom it's hard to interact, and I think motivational interviewing is very interactive, and so if you're able to, please say hi in the chat, say where you're from, where you're dialing in from. Would love to meet you virtually. All right. So as Tess mentioned, I'm a psychologist, and I have learned motivational interviewing about 20 years ago. And I learned it in graduate school when I was at the University of Washington in the context of a program for college students called Basics. And Basics was basically a program for when college students were busted for drinking on campus, they had to come to us for a one-on-one session to talk about their drinking. And so as you can imagine, for someone busted for having fun, drinking on campus, meeting with us, they came in with a certain rigidity. They came in thinking that we were gonna yell at them, that we were gonna lecture them, that we were gonna tell them everything that they needed to know about alcohol. And basically they were expecting this confrontational, this judgmental approach. But the beauty of Basics is that it uses a motivational interviewing style. And a motivational interviewing style focuses on your words. It focuses on ways to build the person's intrinsic motivation, their ideas, their values. It's non-confrontational, non-judgmental. And so while these students would come to these sessions with their arms crossed, very resistant, I loved these sessions because by using MI, it opens the invitation for them to talk, for them to consider change. And that's what the research shows. In this particular program called Basics, a year out when students came to it, ironically, 90% would say they would recommend the session to a friend. And a year out, we found that alcohol reductions happened as well as alcohol-related consequences reduced. So it's a really nice harm reduction approach. What happens in our field, whether you are in a community health setting, PCP, school setting, is that there is this curse of the writing reflex. And in MI, the writing reflex says, I'm right, let me tell you what I know, let me give you information, let me tell you exactly what you need to do to get help. And it's very advice giving. This is what the college students were expecting they would get. And it's a fixing reflex. It says, I'm the expert, let me tell you what you need to do. And of course, it's born out of concern and caring. When I see a patient in my clinic and they're struggling, I want to give them advice. I want to help them. I want to tell them exactly what they need to do to get back on their feet. And it's problem solving, right? The problem with the writing reflex is that it oftentimes engenders resistance. So oftentimes when you tell people what to do, they get even more standoffish. When you persuade and you try to give them information, unfortunately, sometimes people take it in a different way and they kind of back off. And so what I'm going to do today is I'm going to talk about motivational interviewing. I'm going to give you 5 tips for how to do it successfully. If you know motivational interviewing, awesome. I'm glad that you're here because I'm going to give you some tips that are more advanced MI that is consistent with the literature. If you're new to MI, welcome. Glad you're here. Absorb it, be a sponge. And at the end, also give some resources because within an hour, it's hard to adapt really well. But it's a great first step if you're in that position. The tip number 1 is that persuasion is not motivational interviewing, and it doesn't always work. This diagram of this comic kind of shows, the best way to achieve good health is to take care of yourself, your lifestyle destroying you. The provider says you should change this, you should change that, you should start this, start that. The patient says, you're right, doc, thanks. And thanks, man, I've got to find another doctor. The truth of the matter is that when we see our patients, within a few seconds, they will either kind of mentally stick around or check out. And our words and what we say directly correlates what they think in their head about either sticking around or checking out. And so persuasion doesn't always work. And if you're the type that persuades, I am. Whenever my husband is in a problem, I like tell them what exactly they need to do because I want to help them. If you are that type, be aware of that. Use your CBT skills. Recognize the thoughts. If you're encountering teens that continue to drink or use, you may have thoughts like, I'm not helping them. They don't care. They're never going to change. And automatically that behavior of the fixing reflex, that persuasion, that advice giving may come out. Sometimes when my clients are super quiet, that's when my advice giving will come out. And so if that is you, be aware of your thoughts, be aware of those behaviors, and just pause for a second and see if you can fit in any of these MI skills we'll talk about today. Breathe, listen, follow, reinforce their values, and empathize with where they're at. So the definition of motivational interviewing is here. Motivational interviewing, it's a collaborative conversational style. I describe it as another way to speak a language. It's like learning Spanish, Chinese. It's the words that you use. And the words that you use are meant to strengthen a person's intrinsic motivation, what's important to them, their values, what's motivating them, and their commitment to change. So my first question to you that I'd like to pose in the chat is, what do you notice about this adult and child? What kind of feelings does this invoke? Happiness, joy. Thank you, Daniel. Great. What else? Involved. Yeah. He's watching over her. Very playful, very fun. Julie, I love that. Following her lead. You get an essence of the adult looking over his shoulder, really engaged, really wanting to be together. I like that, Miho. And you can see the joy on the child's face. It's playful, it's inclusive, it's fun. The adult is not afraid to put on the tutu and the tiara to be together. You can tell that Amanda, the adult, is not telling her what to do, but instead they're in sync. No one is ahead of the other. And so MI is described as dancing versus wrestling, really trying to be in her imaginary world, right? Really trying to empathize what they're going through. And so MI is about dancing versus wrestling. And it starts with engagement. And so that's tip number 2. Engagement is the key to motivational interviewing. Really trying to figure out what the client's values are, what's important to them, how they're feeling at a particular moment. And it takes spidey sense. Spidey sense in terms of listening and really working on the relationship. And we start motivational interviewing with that engagement, because without that trust, it's hard to do work after that. And especially when it comes to cannabis use, substance use, and mental health, you gotta have that trust before you move on. And so the phases start with engagement, where you really start, tell me more about you. Tell me about how your day is going. Tell me about the things that are important in your life. And you focus in. We have about 15 minutes here to meet together. Tell me about what's on your mind. What are things that you want to work on? If you know that cannabis is your target behavior, and let's say a parent referred them, I know that your parent wanted you to come in to talk about your weed use, but tell me what's important to you. Tell me what you want to talk about. And you work with the client or the patient to negotiate what that target behavior is. So now we know it's weed use, let's say. Then we use our evoking comments. This is my favorite phase of MI outside of engagement. And this is where you use your open-ended questions and your reflections to really get the client to talk more. The goal of MI is to get the client to talk more, but it's also in a direction that evokes change. Tell me more about why you want to talk about your weed use. Tell me more about what's important to you. If you had ideas about cutting down your weed use, how might you do it? It's getting the client to talk more about change, and you use your words to evoke that in the client. And then finally, the last stage is planning. This is how you'll get there. So you told me that you're interested in cutting down your weed use. It sounds like one of the ideas from what you've shared is cutting down your social time with so-and-so. Tell me more about how you might do that. The phases are somewhat sequential, but they bounce back and forth. And what I want to highlight here is that planning is at the very end. What happens to us as those in helping professions is that when our patient is interested in change, like they give a little bit of nuggets in terms of wanting to change, we jump straight into planning. Oh, maybe I should cut down my weed use. Oh, how would you do that? Tell me more about that. Or we jump right into advice giving. And we almost skip these early phases of engagement, focusing and evoking at our detriment. Because if we don't know what the carrot is in terms of what will motivate their change, we have less leverage. We have less ammunition or supply to really encourage the person to change. So if someone says, maybe I do need to cut down on my weed use, you might ask instead, tell me more about why that's important to you. I hear that you're really interested in making a change right now. Tell me more about why that is. And you really focus on that engagement piece before you get to the planning. Because more than likely, if you get them to talk about why it's important to them, you may not need to engage as much in the planning, because they will have that self-efficacy, that confidence to decide what the planning is for themselves. The truth of the matter is that we all have values, whether it's sports, school, family, community. And so motivational interviewing is about grabbing what those values are and really voicing them out so that the client knows why they're doing the certain things and behavior. So how do we do it? In MI, there's an acronym called OARS, and it stands for open-ended questions, affirmations, reflections, and summaries. And hey, if you're great at open-ended questions, that's fantastic. These are the ones that start with what, tell me, how, and why. And here's the advanced MI tip. If you're great at open-ended questions, what you want to do is you want to phrase your open-ended questions so that you get change talk. And I'll talk about that in a little bit. So you can strategically phrase your open-ended questions so they say something regarding change. So let's use an example like drinking. If someone says, maybe I need to cut down on my drinking, I don't want to ask what's getting in the way. Because if I ask what's getting in the way, They'll go down the path of all the barriers that are getting in the way. What I want to do with my opening questions is ask them, tell me more about that. Why is cutting down your drinking important to you? Because I want to switch the path for their language to be all about change. I want them to talk themselves into change, talk about all the advantages, what's driving it, what's going on in their life, so that they can really talk themselves into change. Affirmations are great ways for you to catch an enduring strength about your client. I see your persistence. Family is so important to you. You will do anything to be a good father. You're really patient. Loyalty is super important to you. And so these affirmations kind of evoke the touchy-feelies in people, you know, because when you get it right, the patient feels, oh, they really get me. They really understand. And you use reflections to say those affirmations. And we'll talk about that a little bit in a bit. So when we are thinking about behavioral change, you know, think back to New Year's resolutions. We are always in this moment of ambivalence. For me, it's caffeine. I'm always kind of wrestling with cutting down on my caffeine, my coffee, and I wrestle with the pros to doing that, to cons to doing that. And in motivational interviewing, as I mentioned before, the goal is to get the patient to talk more about the pros to cutting down or to changing their behavior versus the cons. So if someone were to ask me, for example, what's getting in the way of you cutting down on my coffee, I'll go to town. I'll tell you all about how it makes me alert, how I love it, how I love the taste. It's just part of my routine and it gives me a boost in the morning. And my language will always go to the cons. And I'll probably talk myself out of it. And so in MI, your goal is to talk about the pros. Tell me more about why you want to cut down on your coffee. When you do, what does that give you? How does that feel? How might you do it? And so the goal with the MI, again, is to talk about the pros. There's a term called change talk in the motivational interviewing research, which basically refers to when the client talks about change, and the antithesis of that, the opposite of that, is sustained talk. That's when clients don't talk about change. And the idea in the research shows that what we'll do is we'll actually record in these research studies these therapy sessions between a counselor and a client. And what we'll do is we have a coding system to measure what is the counselor doing, like what types of MI tips and tricks are they using, and we'll measure that and we'll code it in these audio recording sessions. And we'll also record what the client is doing. We'll kind of rate what they're saying, if it's change talk, if it's sustained talk, if it's something else. And what we can do is we can sequence the counselor and the client talk. And what the research shows is that when counselors provide opportunities through their open-ended questions and reflections for the client to talk about change, that increased change talk is associated with reductions in substance use. When counselors or therapists or providers do the opposite and ask about sustained talk, that sustained talk, and this is more powerful than the change talk finding, increased change talk, that's language in opposition of change, is associated with greater substance use and fewer readiness to change behaviors. It's just like that comic, right? Within a few seconds, you know, being kind of increasing that change talk that they don't want to change. And the research shows through these sequencing and these audio recording sessions is that providers, us, we directly influence whether or not a client will say change talk or sustained talk. And this is common in groups too. So I do groups with youth and adolescents, and the way we phrase our questions is almost even more important than one-on-one sessions, because in a group setting, what happens is that whatever the peers are saying, it gets contagious. So as one person talks about sustained talk, it invites another person to talk about sustained talk. And if you get them to snowball, then the whole flavor of the group is negative. And so as a group facilitator, I have to make sure I intervene. So I hear that you're not ready to cut down your weed use. I wonder, What are some ideas that other people have that have helped them think about changing their weed use? So I try to use my questions and my reflections to steer it in the opposite direction, so I get people talking more about change talk, and that you don't get this iatrogenic effect of people talking more about sustained talk. So I'm going to get you guys to practice in just a minute, but I want to give some examples of common sustained talk things that people might say. So imagine a client of yours saying, I don't have a problem with my drinking. You know, this is a person maybe in the emergency room department that just came in for a DUI, got in an accident, and they say, I don't have a problem with my drinking. Common sustained talk phrases could be, why do you feel that way? So why do you feel that way is a common question that we ask. But in the context of this statement, I don't have a problem with my drinking, then that kind of encourages them to say more about why they don't have a problem. So that would actually encourage sustained talk. Same thing with tell me more about that. But you just came in with a BAC of 0.2. That would also engender more sustained talk. Similarly, you just got arrested, your lab results show that, etc. And so the way we phrase our questions are really important. So here's an example of how to respond to the same statement without sustained talk. So tip number 3 is to guide the person to change talk. I'm glad things are going well for you. By saying that, then the patient or the client continues to talk about what's going on well for them, and you may get glimpses of what their values are in that moment. I'm doing fine at work. You know, I'm going I'm getting to work on time. I've had no issues. I show up for my kids when I have to pick them up from school, and then the reflection comes in. So being responsible is super important to you. Again, the first phase of MI is engagement. What are the client's values? What's important to them? And you want to grab at each of those little hints of values. You might ask open-ended questions. What does having a problem mean to you? The next one is my favorite. How would you know if things weren't going well? What concerns do you have? What concerns do others have about your drinking? Here are some reflections. Being healthy and responsible are important to you. And then summaries. What I hear you saying is that you worked hard to keep your drinking under control by drinking less. Things are going well for you. You're getting to work on time, you're exercising more. I wonder if we can chat about ways to continue preventing future problems. Sometimes I'll say, I hear you. I hear that right now you don't think you have a problem with your drinking. And I want to partner with you on that to keep that up. How might we partner up together? How might we know if things are getting out of control so that we can stay on the right path? And maybe they give you hints about what to look out for. Tip number 4 is to wait for it. And by waiting for it, that means waiting for the change talk. And to do this, you need to listen empathically. Sometimes after therapy sessions that I do with my clients, my brain hurts. I'm trying to listen so hard for those nuggets of values, reasons, because by catching them, it becomes really powerful. And so to do this, you want to use your reflections. So reflections are statements rather than questions. So if I were to say, family is important to you, the reflection sounds exactly like that. Instead of, family is important to you. You don't want reflections to sound like a question because it'll come off as a closed-ended question and they'll just say yes or no. Family is important to you? Yes. The goal of motivational interviewing, again, is to get the client to say more. You want them to do more of the talking. You want to mimic that dancing picture that I showed you earlier, where you're following their lead. But in order to follow their lead, they need to talk more. They need to share what brings them joy, what's important to them. Reflections make a guess about the client's meaning. So it's rather than asking, you say that statement, and the beauty of the reflections is they continue on that statement. So after saying something like family is important to you, then they'll continue on. Yeah, you know, we've gone through a lot. My mom has been there for me through thick and thin, and she really gets me. And I just love that she supports me. Having your mom by your side has really carried you through. And then they'll just keep on continuing on the sentence. And it's really beautiful when it happens. Reflections often yield more information and better understanding than a question. When you do motivational interviewing well, this is the advanced MI technique, you'll often see that you're doing 2 reflections to every 1 question. And the reason why you want to do more reflections than to questions is because when you do too many questions, it sounds interrogating. Like too many questions is, it's not as engaging in the conversation. Sure, you may have your assessments. And so when you do your assessments, those questions are just fine. But when we're talking about the meat of the session, when you're really talking about behavioral change, where this MI will come in, that's where the strategic reflections and more frequent reflections are important, as well as those directional open-ended questions that we talked about. Reflections show empathy. So empathy is actually quite measurable. When we find is that reflections often generate meaning in terms of the client understanding that you understand them. And so low empathy providers are actually worse than not having any provider or treatment at all. The research shows that empathy can be very reliably measured, just like in those audio recordings that I mentioned earlier. In that research, you can measure on a 1 to 5 scale how empathic the provider is, and there's very strong inter-rater reliability. And so what you want to do is you want to have as much empathy as possible, and by using your reflections. Empathy is not having the same experience or problem. Lived experience is incredibly valued, but you don't necessarily have to have lived experience with what the client is experiencing to be helpful to them. In fact, you don't have to have lived experience to show empathy either, because there's no way that we can have 100% experience from what the client is sharing. Empathy is not identifying the client. I know what you've been through. I've been through that as well. Let me tell you my story. Empathy really is accurately understanding the client's meaning. And for those of you with lived experience, you're likely to get at that empathy much quicker. It's the ability to reflect that accurate understanding back to the client. So if you're new to reflections, there are different ways that you can do it. And for those of us that have been in school, I use the word like plagiarizing and paraphrasing. So the simple reflections are when you plagiarize. You just repeat their words. So if a client says, I don't have a problem with my smoking, you say, you don't have a problem with your smoking. And you just repeat their words. When I was first learning motivational interviewing, my supervisor would tell me that if you don't know what to say, just repeat what they have to say, and they'll continue on your sentence. And they did. Now, you don't want to do this all the time, right? Because then they're going to be like, why are you like repeating everything that I have to say? It will sound like an echo throughout the session. But if you're stuck, this is the first way to start. You want to mix this in with complex reflections. Complex reflections paraphrase what they have to say, and they reflect emotions. So let me give you some examples. Having a problem would mean that your weed use was getting out of control. So same statement, different words. And you can see that by having different words, you can have more impact in what you're having to say and what they'll say next. My favorite complex reflections reflect emotion. You're concerned that people are worried about you, and being healthy and responsible are important to you. And so reflections run the continuum. When you get into more of the advanced MI space, you'll have more complex reflections that really heighten what they have to say. And it's okay to heighten what they have to say, because if you don't get it correctly, if you don't get it correct, they'll correct you in a very safe and inclusive way. No, I'm not concerned. I just worry that whatever. So they'll correct you in a very safe way. Okay, so now I'm going to open up the chat function because I want you to practice. Motivational interviewing is all about practicing with your words, trying to figure out what you would say. And by doing that, you start to get more natural. And sometimes when you first start phrasing your questions and your reflections, you kind of have to think about it and pause. And that's totally okay. Do what you need to do. So what I'm going to do is I'm going to put a statement on the screen, and then I'm going to have you chat some reflections that you might say. Okay? All right. The first item is, I'm depressed and nothing seems to be helping. What's a reflection you would say here? You're feeling really down lately. I love it. Thanks, Kelly. What else? You're feeling depressed and nothing has worked to feel better. You don't know what to do next. Lovely. You're feeling depressed, having tried a lot of things to feel better. Wonderful. These are fantastic reflections. It sounds like you feel like nothing is helping. Nothing is changing your mood or outlook. Terrific. Okay. These are great starter reflections. Now what I'm going to do is I'm going to challenge you to have some direction into them. So if I reflect to this particular patient, nothing seems to be helping. They're likely to continue talking about how nothing seems to be helping. So remember that fork in the road that we talked about? They're more likely to talk about the cons. Nothing seems to be helping. I've tried medication, I've tried therapy, nothing seems to be helping. I don't know what the use is right now. And so if you wanted to be directional in your reflections, you might say something like, you're curious what else is out there that can help. You've put a lot of effort into trying to feel better. I like that, Amanda. And so the way you craft your reflections will predict what they will say next. So let's try the second one. You're wondering if anything will help. Nice, Kelly. Weed is natural. I'm sure you've heard this more than once. Weed is natural. It's not like I'm smoking heroin. Nothing seems to be helping. Good. Oh, I like that. You're still here and willing to try new things. Great work. So how would you do this second one? Weed is natural. It's not like I'm smoking heroin. You're committed to taking big risks with your health. This is a tough one. You view weed as different from other drugs. Ooh, sounds like that there are worse things for your body and others are still worried about what you're doing now. Good. It sounds like weed has been helping you. Tell me more about that. You don't think weed is as serious as heroin. Excellent. Good. There's a value in here sometimes when people talk about weed being natural. What's the value here? What's important to them? I think you got it, Angela. So maybe it's health. Health may be important to them. What I'm hearing you say is that health is important to you. Tell me more about that. You value your health. Very nice, Elizabeth. You smoke, but you value your health. Great. In this statement also there's some judgment about, at least I'm not doing that, right? There's some sort of judgment in there, and that could be a source of reflection too. It's important to you that people don't view you negatively. It's important to you to be healthy, to be on track. I like it, Angela. You smoke weed and you value your health. Wonderful. And so as you're chatting, make sure you chat to everyone so that people can see your reflections. Great, Julie, thank you. I love the interaction. Thank you for doing that. Okay, here's the next one. There's 4 of them, by the way. I don't want to use again. It would be awful. Think about what value you see here. How can you directionally reflect this statement? I don't want to use again. It would be awful. Love it. That's it, Amanda. You're committed to avoiding those worst case outcomes. I might even personalize even more. You're committed and you know you're committed and you don't want to go down that road again. I hear that you're worried about using. How would your life be better if you stay sober? Love it. You're committed to being sober. Terrific. You guys are getting the hang of it. I love it. How about this last one? I know what it takes to stop using. I'm just not ready now. You plan to quit using in the future. Nice. What would make you ready to stop? Good. You are self-aware and will stop when you are ready. Terrific. So I love that you all are picking up on the direction. You have so much knowledge about yourself and your recovery journey. Excellent. You know what resources. Terrific. So I think you guys are getting the gist, right? What we focus on reflecting will directly predict what they'll have to say next. So we don't want to focus, I'm just not ready now. You don't want to focus on that part. You want to focus on the change part of it. I can tell that you're ready to go. Tell me more about what you want to do next. Or if you are trying to do that engagement, it may be, I hear that you're really motivated to stop using. Tell me what's driving that motivation of yours. Maybe you focus on that engagement and kind of get that intrinsic. Good. Okay, so ORs, open-ended questions. We talked a lot about reflections. In the middle of that is affirmations. And these are really focusing on their strength and capacity. For that last reflection, it may be you are really persistent. You are ready to go. Being on top of your life is important to you. Affirmations often begin with you. And these are like compliments of enduring qualities. They're not these cheerleaders, like, thank you for coming in today. Those are nice things to say, but affirmations really get at the core of someone's being, their strengths, their grit, their characteristics that make them who they are. With all the obstacles you've overcome, and now this latest one, you just keep on going. You're someone who is really determined when the going is rough. Okay, so I'm going to keep us going. And I want to share this last tip of giving information in a sandwich. So I often use, I do therapy in our addiction medicine clinic, and they're brief encounters sometimes. Sometimes I'll only see people once, sometimes I'll see them for more extended therapy. And in those medical settings, we often have to give information, right? Whether it's about medication, whether it's about therapy, whether it's about a specific diagnosis. And ethically, we have to give information, and that's okay. But you can do it in a MI consistent way. And the MI consistent way is this elicit, provide, elicit sandwich. And you first start off with a question. My favorite question is it okay if I share some information with you? And I saw that some of you said that in the chat. Is it okay if I share some research with you? What happens is when you ask for permission, they always say okay. They always say, yes, it's okay to share that with me. But what happens is that it opens the invitation and it tells them that you are interested in their opinion. You want to know and you want to get their endorsement that this is okay. This is what engenders trust, right? When you don't just dump information, but you get them involved too. So the sandwich starts with elicit. Would it be okay if I shared some information with you? What would you most like to know about cannabis? What would you already know about Suboxone? Whatever the questions are. And then you provide the information, and you provide it in a neutral manner. And you do it in a digestible chunk. You don't want to go stories and stories and stories, but you want to do it in a digestible chunk. And then you follow up that sandwich with another question. What do you make of that? What do you think of this information? What more would you like to know? The thing about providing information is that you can often get into a trap of that fixing reflex that we talked about earlier in this presentation, where you just give advice, where you just persuade them to change, and you only do that middle meat part of the sandwich, that provide. And so to do MI in a consistent way, I encourage you to do the elicit, provide, elicit, where you sandwich the questions. Another tool that I often use in like brief encounters are these rulers. So I often ask two different rulers. On a 1 to 10 scale, how confident is actually I start with the importance. So I say on a 1 to 10 scale, with 0 being not important and 10 being important, how important is it to change your whatever the target behavior, weed use, is right now? And they'll give a number between 0 and 10. And what I do is I follow up with a couple of questions afterwards. And again, my tip is to really get at the change talk. So I say, on a scale from 0 to 10, 0 being not important, 10 being very important, how important is it for you right now to change your weed use? 3. My first question is always, tell me what a 3 means to you. I listen to these recordings all the time with people doing rulers, and if a patient says 9, a provider will always say, that's great, you're at a 9. But they kind of impose their judgment of what a 9 means to them. The goal of MI is to get them to talk. So always ask what their number means to you. So if they say a 3, tell me what a 3 means to you. If they say a 9, tell me what a 9 means to you. And the second question that I always ask is, tell me why a 3 and not a lower number, like a 0. Tell me why a 3 and not a 0. And the reason why I go lower is because, again, I want them to talk more about change talk. I want them to say, well, I'm not at a 0 because I know that it is important to be healthy. That's change talk. I don't want to say why a 3 and not a 7. Well, I'm not at a 7 because I don't have a problem and it goes down the other route. And so again, the way you phrase your questions will predict what they have to say. And so I encourage you to ask that importance question. I also encourage you to ask the confidence question. So on a scale from 0 to 10, 0 being not at all confident, 10 being very confident, how confident are you that you could make a change if you wanted to? This gets at self-efficacy. This question is really important because it may not be that they are interested or find it important to change right now, but they're super confident that they could if they needed to. And so this is another angle to get some change talk in. So maybe they're at a 2 in terms of, or 3 in terms of importance, but they're at a 10 in terms of confidence. Tell me what a 10 means to you. And tell me why a 10 and not a 5. And I avoid these 1-point differences. I don't say, tell me why a 9, a 10 and not a 9, because I go for the drama. It's easier cognitively to really talk about differences when they're wider. And if they're higher in their confidence, then that's your opening. Okay, so I hear you saying that you're really confident that when you're ready, you got this. Tell me about what you would do. Tell me about some baby steps that you would take if you were ready to cut down on your cannabis use. So those are different ways that you can use the rulers, you can use the elicit, provide, elicit to generate some quick change talk. Okay, so here are your last tips. So number 1, persuasion is not MI and doesn't always work, but it's incredibly common in our helping profession. Tip 2 is to start with engagement. Don't jump to planning, start with engagement. Figure out what their values are, what motivates them. Number 3 is to be strategic with your orders. Really guide the person to change talk with the words that you use, and wait for the change talk. Continue to fish for the change talk. Listen empathically with your reflections. Remember that 2-to-1 reflection ratio. Using more complex reflections that reflect value and paraphrase versus the simple reflections that just plagiarize or copy what they have to say. And then tip number 5 is to give information in a sandwich. Hey, if you need to give information, but do it in a way where you ask permission first, give the information, and then follow up with a question about what do you make of that? What more would you like to add to that? And then see if you can squeeze in the rulers too. Okay. All right. If you're interested, I'm going to give some resources in just a bit, but this is a nice chart from this workbook by David Rosengren. David has done a really nice job and has had multiple additions to his MI workbook. It's just like a self-help type of thing where you can do worksheets. If you're like me and like to write things down, this is something that you can do. But if you're new to MI, these are kind of ways in this first column where you can kind of gauge your proficiency in the very beginning. If you're less new to MI and you want to kind of assess where you're at in terms of your proficiency for MI in the advanced stages, this is where you might be. So here's a 2-to-1, using deeper reflections, really thinking about the directionality, steering someone away from sustained talk. These are really nice ways to measure where you're at and what you can do more of. I do a lot of research at RAND. If you are working with youth, there's an opportunity where we're just going to do like 1 to 2 focus groups with 18 to 19-year-olds. You're welcome to take a quick screenshot, but if you work with any teens that would be interested in participating in our focus group, we would love to invite them in. I'm very interested in this transition after people leave 12th grade, and really researching ways to prevent the drop-off, especially for those that don't attend college, and how we might reduce the risks of substance use after seniors leave high school. And so we're recruiting for a couple of focus groups so that we can get youth stakeholders to share with us what helps and what doesn't help them. And here are the resources that I mentioned earlier. This first website is a really nice one. If you're familiar with ASAM, I highly recommend any of Dr. Brian Hurley's talks. He does great workshops with MI. There's a lot of CMU opportunities on the ASAM website for MI as well. This group MI for Teens is a wonderful website too. I was a part of it where we used some funding to disseminate a lot of our manuals that we've done with teens, like the group teen program that I mentioned earlier. There's also middle school programs for substance use. There are all types of videos related to motivational interviewing in groups that you can also do. And then here's some nice books that I would recommend. This last one is the Rosengren book. That's the one where it has that table. All right, so I think that is my last slide, and we wanted to open it up to any questions that people have.
Yes, so as a reminder, first off, thank you, Dr. Osilla, for that wonderful presentation. We do have a few minutes left for some questions, so if you are interested in getting Dr. Osilla's feedback on anything, her thoughts, please use the Q&A feature at the bottom of your screen to submit a question to us. As a reminder, this webinar recording and the presentation slides will be available on our website in the coming weeks, washtenaw.org/marijuana. So you'll be able to have access to her slides at that website. So I did have a question to actually get us started. How do your motivational interviewing techniques change based on the age of your client?
That's a great question. I don't think my MI skills change by age, but they change by readiness to change. So if a particular person that I'm talking with is less ready to change, then I put my MI in fuller gear than it would with someone that's already motivated, really working hard to find the values, really working hard on the engagement. So I would say that my MI skills kind of more fluctuate based on readiness to change versus age.
All right, and in the Q&A, Amanda asks a question. What are your thoughts about exaggerated reflections? Like someone says, I don't have a problem with alcohol, and the reflection magnifies that into you've never experienced any negative impacts of your alcohol use or similar.
That's a good question. I think exaggerated reflections could work well if that engagement part of MI has happened. I think if you've already engendered some trust with the patient and they know you a little bit more, it's okay to do those exaggerated reflections because then they'll correct you. They feel safe in correcting you, you know. Otherwise, sometimes I think people can be put off a little bit, especially if they don't know you yet. That's a great question.
And another question I had, what is the best way to measure your own success in the use of motivational interviewing? So say I've gotten started and I'm trying to implement these techniques with my clients. How can I gauge my success?
Oh, that's a fantastic question. I think you can gauge it based on what your client is saying. So if because what you say directly influences what they say. So if you have a client that is talking more about change talk, then you know that the questions and reflections that you're saying are really great. You know, when I do training with fellows, I actually have them audio record a session so that they can listen in on how many questions and reflections they have to say and what directionality they have. So if you're in a training program, and you have the opportunity to record a session, I highly recommend it. You know, we don't know what we say until we actually listen to it or someone else listens to it for us to catch the nuances of the things that we have to say.
Thank you.
Sure.
And it looks like in the chat, there's a couple of questions.
Mm-hmm.
Angela asked, do you have resources on facts about marijuana to use during MI? Especially for teens that are not in an abundance of true facts to provide to them about their use.
All right. Yes. So on that Group for Teens website, Angela, there is a cannabis program for teens. The free talk program is one for older teens, and this was for high school students that were in teen court, where we did group MI. A lot of it was with motivational, was with cannabis, and that would be a nice resource. There's a manual up there that's publicly available, handouts. There's some games like kind of debunking some of the myths around alcohol and cannabis, and that one might be a good one.
And Katie has asked, can MI be used in groups as effectively as one-on-one?
Absolutely, yeah. Group MI is more well studied now, and the literature is growing on group MI. There are some really nice books on group MI as well, and it can be really powerful. Because when you're able to kind of steer the change talk in a group setting, then your multiplier is times whatever number of people are in the group. Because peers and like co-students in the group can often be more powerful than what facilitators say. So I think MI in groups can be a very powerful experience.
Wonderful. I think we may have gotten through all the questions in the chat. Any last call for any questions while we have Dr. Osilla at our disposal here? But thank you so much. This has been wonderful, and I've really gained a lot of, I loved the tips and tricks that you have to have in your back pocket in those tricky situations when you run out of things to say in response. So thank you so much for your time today.
Wonderful. Thank you all for putting things in the chat. I loved hearing your reflections and the ways you would connect with patients. So thank you for all that you do on the front lines as well.